Given that the CPSO last year had a report regarding the information that doctors were given about opioids, and they were told by the pharmaceutical companies, that, especially Purdue, I guess, that these opioids were safe and were effective. And in the College of Physicians and Surgeons report last year, they clearly highlighted the fact that this was not the case at all. And a lot of people have become addicted, whether you call it dependence. I see the difference, and I appreciate your explanation. However, to me, if it walks like a duck and it quacks like a duck, it's a duck. And when do we know that we go from dependence to addiction? Is it because someone is continually getting their drugs from a legitimate doctor, and then the doctor says no more, and then they can't obtain the drugs, and they don't necessarily get them because they are want to get high at this point, but to maintain a sense of normalcy? So my question, I guess, is what is the medical community doing? Because a lot of the dependence and addiction has been created by our very medical community. And yes, there are lots of young people that will experiment with drugs. They'll experiment with glue, yes, we know that. But the majority of the deaths, overdose deaths, and addiction is coming from people who are hardworking, have an accident, go to their doctor, get a prescription. They're not educated, the doctors, on what these drugs do, because they receive the information from the drug company who wants to promote their bottom line. So my question is, what is the medical community doing to educate themselves from an independent source and not a drug company who wants to push these drugs?
Okay, good question.
I would say the guideline, the guideline is, so the Canadian guideline for safe and effective use of opioids for chronic non-cancer pain was developed by all the colleges of all the provinces and territories in Canada, not only Ontario. It started in Ontario, but all the provinces. So it's a Canadian guideline. So it was developed without funding from any pharmaceutical industry. It was developed based on evidence. And the National Advisory Panel, the 49 individuals that participated, they reached consensus on all the recommendations. So the guideline was released May 2010. And then since then, the national faculty, which is the one that Dr. Buckley heads, and I and Beth, we are members. The Canadian Pain Coalition is also represented. The national faculty is a body of people, 39 people, who are interested in pushing the guideline, the messages of the guideline to physicians, to pharmacists, to people prescribing, to educate. So we want to educate those physicians who are not prescribing opioids because they are afraid and their patients are suffering unnecessarily because of pain. So it's not acceptable that a physician says, if a physician says, I'm not prescribing because this patient is at risk and I'm not feeling comfortable and I don't want to prescribe, that's one thing. But if the physician did not assess the risk, is against opioids and is saying, I'm not prescribing because I don't want, I have a policy, I don't prescribe, that's not appropriate. We want to educate them how to use the guideline. So the guideline is also to promote the appropriate use of opioids for those who need. On the other hand, the guideline is also meant to help those who are at risk of overdose and dying, risk of misuse, abuse, addiction, diversion, to get other options to treat their pain. So it's a two objectives. So that's what the community is doing. That's what the colleges and that's what the universities are doing. We are creating courses, we are creating workshops to educate the community, the physicians and those who prescribe opioids, to do it safely and appropriately. How long this is going to take, we don't know. We don't know if it's going to be successful or not. but we hope that this is going to help those who need the medications and will take, and those who don't need the medications, and someone will say no to them. We know that the pharmaceutical industry has a big interest in promoting these medications. We all know this. We get visits from drug reps, and they tell us that it's safe, but we have to wait what really each patient has. We have to assess the risks. We use validated tools. We use urine drug screening. We send them to addiction specialists to do a consult to see if this patient is getting into trouble or not. So we have many things that we can do to help our patients, just not to be liberal prescribers without thinking.
I think we also need more publicly funded, we need publicly funded pain management programs in Ontario. There are none, it's all private pay. And these poor people who are at risk get lost in the cracks because they don't have the proper education as a person who lives with pain and their family around them to deal with the issues. Unfortunately, people that live with chronic pain have twice the risk of committing suicide than the normal population. And that just shows you how poorly managed pain is, because if you're feeling suicidal because you live with chronic pain, then something's wrong. You're not being managed properly.
There's a series of interesting questions that come out of this process. Some of them are written up here. Did you want to make a comment, Beth? Or?
Well, I guess I was just going to echo what Andrea said, that from that CPSO document about tackling the opioid public health crisis, that it made a number of recommendations about education of healthcare providers and highlighted the point of how little education is given in undergraduate programs and continuing education programs. And so, as Andrea and for that, we are working on changing that, certainly in the pharmacy curriculum and in medical curriculums across the province, trying to improve that, trying to help doctors assess that risk that we've been talking about, and I guess we've never really talked about what those risks are. And from what we can tell at the moment is that you really need to be cautious in people. The main risk factors that we've identified so far are people who have a previous substance use history, so problems with other substances or previous problems with opioids, obviously, but it could be any other substance, alcohol problems, that they're likely at higher risk to running into problems with their opioid. And also people with mental health problems who are suffering with some psychiatric illness that may or may not be treated appropriately are also seen to be at higher risk of potentially running into problems with their opioids. So helping to educate healthcare providers about assessing those risks and including those risks in their decision making, and it may not be just in the decision of whether to use opioids or not, but again about how closely some patients may need to be monitored, some more closely than others, if they're identified at being potentially at higher risk, that maybe they shouldn't be getting a month's supply at once, or need tighter boundaries and more monitoring to try and help prevent that. But I think at this point we're looking at it that education is really the key, as opposed to more strict things like limiting the doses that can be used in patients and restricting I guess sort of coming up with restrictive licenses that only certain people can prescribe opioids, those types of things that have the potential of really limiting access to these drugs even more. So I think education is really a good way to go with this, so as to keep it available but still trying to help reduce the problem.